What are our objectives going to be today? The objectives are going to understand the players that are included as well as the process involved in establishing a treatment plan, a medication treatment plan. So we're not going to speak only about medication. We're going to talk about how we get to the point where we say, okay, this child needs medication. That's very important when we discuss compliance issues, when we discuss appropriate treatment and appropriate diagnosis. We're also going to identify the psychiatric medications that are used more often in the population that we're serving. Again, any age from 3 to about 17. And also understand the risks, benefits, and possible side effects of the medication that might present in the school milieu, that might present in the office of the therapist, that will present also at home. That affects the treatment outcome. So what happens before starting medication? Well, medication is not something we just pick arbitrarily. Unfortunately, in child and adolescent, in the kid population, in the child population, even though studies are increasing in number, there's still a great limitation in the studies that can be done or are completed in children. I say basically because there's not a lot of parents that want to set their kids out there and say, okay, try a new medication on this child. So a lot of our decisions are based on the studies that are done in adults. But of course, this is improving as time goes by. We're able to do studies in a much safer way in children as well. So the initial evaluation, how we meet the child, this is the beginning of treatment, possibly with medication. It's usually by referral. The referrals, the main source of referral usually for a child or for the parents to send the child is in school. Why? Because they spend most of their time in school. So at that point, you see the mood swings, if there are any, you see the peer interactions. You can also see the difficulties that occur in academics, in being able to sit down in their chairs, in paying attention, or just behavioral issues in the classroom. So the teacher or teachers become a point of initiating diagnosis or a point of initiating an evaluation. Then we have the therapists and the counselors. A lot of the children, a lot of the families go to counseling first or go to the therapist before they ever go to the psychiatrist. And then the therapist helps us because they start identifying, well, there are some issues that we can just not treat in therapy. Something else is going on. And so they're referred to the psychiatrist. Other MDs, well, we have the pediatricians. The kids go to the pediatrician, the parents report some symptoms, the pediatricians say, well, I think you need to go see this other physician, this psychiatrist. Family practice docs also are another source of referral. And then who else? We have family members. When family members start mentioning, something's going on, maybe you need to take him to see a psychiatrist. And self-initiated. Unfortunately, self-initiated referrals or self-initiated appointments are not very common. And it's usually because the parents don't necessarily know that there's something wrong, or they think that maybe it's because of their lack of parenting, right? Or the child's lack of will to follow directions that this child is having problems. So they can't imagine, it's just not something that is easy to sometimes even accept, that there might be a medical problem. And the medical problem in this case would be a psychiatric or mental health problem. So after the child has the appointment, or initiates in the appointment, what do we do? Well, it depends on the age group, but it's very rare that the child is the only individual that is interviewed. The child is interviewed, usually when it's an adolescent, the adolescent is interviewed before the parent. That way they feel like they have provided the information before the parent gives kind of their maybe negative symptoms or issues. But when we have the little kids or the little children, the younger age groups, it's usually with the parents that they come in. And the questions are asked with the comfort of the parent in the office. Once that relationship is established where the child feels like they can discuss things with the psychiatrist, then you can start having, and the parent also feels like they're more comfortable, then you can start having appointments where you have just the child in the room. The interview of the parents or the guardians is also very important. Sometimes the parents have trouble identifying the behaviors. And maybe the behaviors that are identified by the mother are not the same behaviors that are identified, and we're talking about the negative behaviors, are identified by the father. Or maybe the child responds in a different way to one or the other. So it's very important to have as many sources as you can to try to figure out what the problem is. And of course, in our culture here in San Antonio, there are many grandparents that are involved, and it's very important to have the grandparents have some feedback also, especially if they tend to take care of these kids or the children after school. So they deal with homework, they deal with a situation where maybe there's less structure, where maybe there are 5, 6, a lot of other kids, cousins that are together. So we see different kinds of behaviors. What other collateral information? We have definitely, we always need school information. And the school information, as you can see, are from direct observations. The teacher says, this is what the child is doing, right? Or the counselor says this, or the coach describes what's going on with the child in PE or in sports. We also have the behavioral rating scales. Many teachers receive what we call the Conners abbreviated. Very common in ADHD. We want to see what the behaviors are when it comes to impulsivity and attention, those kind of things. There are also depression scales. And these are just straightforward, more standardized tools. We also have conduct charts, just the smiley face, the frown, those kind of things. Especially in the elementary school kids, it's very important because sometimes things are happening in the home setting, and if we have a conduct chart, we can kind of identify if maybe the home setting, the changes in the home setting are affecting the behaviors at school as well. And then, of course, we have the collateral information from the therapist, which is sometimes very difficult to obtain, not because of the therapist, but because of communication. People are seeing patients, and it's hard to kind of get the schedules together. Then, with all this information, what do? Well, we would like to be able to come to an accurate diagnosis on the first appointment. An hour and a half evaluation, but it's very difficult. It's very difficult. So what we have is usually preliminary diagnosis, and we start getting ideas of what's going on. Not all children, though, even if the diagnosis seemed to be, let's say, ADHD, and we're suspecting that, or maybe a mood disorder or depression, not all children are necessarily started on medication for the first appointment. It depends on the safety risk. It depends on the level of functioning of the kids. It depends on whether the parents are on board with medication, how comfortable they feel. Because at this point, if medication is something like the only objective, then you might feel that the parents are more hesitant to bring the child and have them have some help. So it doesn't always occur in the first appointment. And sometimes this is frustrating for the teachers, sometimes this is frustrating for the kids in the setting, in different types of settings, because there isn't an immediate change in the behaviors. From the diagnosis, we go to the treatment plan. And the treatment plan, one of the main messages that I'd like to give is that the medication doesn't do everything. Right? The medication is going to help, right, with an appropriate diagnosis and an effective response to the medication. It's going to help with the biological component of the mental health issue. But we also have the external ones. And the external stressors can be, for example, the school, right? Just the demands in school, just the academic demands. The child has maybe some learning difficulties, right? Maybe it's an overstimulating classroom. So we have to come up with an educational plan. Sometimes these kiddos need to be in special education also. So this is something that needs to be pursued so that the treatment plan is a successful plan. Referral to a therapist if they don't have a therapist already. Remember, we're dealing with children. They're in the process, even if they might be preteens, to learn how to cope with different types of settings, social interactions, peer interactions, interactions with authority. So the therapist will help with these interactions, as well as with the parents. And then referral for testing, which is when we refer to the psychologist for psychological testing, which helps with the diagnosis. After all this, then we come to the point where we say, okay, well, we need to try, or maybe medication is indicated at this point. And this is when we're going to start talking about the meds in general. But again, medication is not necessarily indicated in all the kids that come in to the appointments. And there are quite a few children that, we say there's more of an issue between maybe the behavioral interventions. There's really no mental health issue. And then we just send the kiddos off to therapy and help the parents with some behavioral interventions as well. Those, of course, are the best appointments. Okay. Before we go into the medications, we're going to talk about some topics that are very important. What is the FDA? We always hear about the FDA. The FDA hasn't approved. The FDA did approve. We use non-approved medications or off-label medications in children. Well, what the FDA does is that they regulate the advertising of a drug or a medication for a certain condition, right? So the FDA doesn't necessarily say that a medication can be used for example, for depression, right? And it can only be used for that. They give kind of guidelines, right? But when we see how many studies there are in meds and in children, you see that a lot of these medications are not FDA approved in children. So as psychiatrists, we try to use the FDA approved medications, right? But if they're not effective, or if there aren't any for a particular group of conditions, then we use the medications off-label. We use from clinical experience, we use from the studies used in adults, then we use the medications in the kids as well, right? So again, the FDA doesn't determine that you cannot use the medications. It doesn't mean that if a medication is used off-label by a psychiatrist, the psychiatrist is like breaking the law or something like that. And this is something very important because FDA is named frequently in the media and the news, and so the parents say, well, no, I only want the FDA-approved medications, okay? And they're not always the indicated ones. Consideration of the dosage of the medications in children. Sometimes we have or we use medications at a dose that is equal to the dose used in adults, and the children are maybe 6 or 7 years old. And so we get, well, how can you give a 6 and 7-year-old the same dosage of medication that you use in an adult? That can't be. Well, not all dosage of medication is related to the body mass or the size. So that's why sometimes you're going to see that sort of kind of, let's say, cautionary dosage. The other thing is that sometimes kids need a higher dose. In stimulants, for example, when we're talking about Ritalin, Adderall, those kinds of medications, and we'll be more specific later on, they'll need a higher dose than used in adults. Because as adults, our metabolism, the rate of metabolism decreases. So the amount of medication needed is less. So we'll go into some specifics. The absorption of medication in kids is faster, and it peaks. It peaks quicker. So the medication seems to kick in faster, let's say, in children. The protein binding, there's less, so there's a greater proportion of the drug that's active in certain medications that have to do with protein binding. Not all medications depend on protein binding. And then metabolism. The liver has a faster metabolism until puberty, and then it kind of evens out, right? So any of the medications that are metabolized in the liver tend to be metabolized much quicker. Therefore, the levels might be lower in children. And then the renal is not such an issue because that's about it equals out at about 1 year of age. Well, how do we determine outcome? Well, we'd like to say that we can see quickly. You start a child on medication, and the symptoms, the behaviors go away quickly, right? Well, we have a limitation, which is the verbal limitation. Sometimes the kids can't describe it. It's not all about behavior. Maybe it's about hearing voices. Maybe it's about seeing things. Maybe it's about just feeling sadness, right? Not all kids can say, I feel sad. They don't even know what the word sad really means. Sad means crying. Well, if they don't cry, does that mean that they're not sad? So there's a lot of limitation that can occur depending on the child's age. Some kids don't even know that they should say, you ask them about hearing voices or seeing things, and they don't know how to answer those questions yet. So there are ways to ask, but even then, sometimes you see a child that's 4 or 5 years old, they don't know how to answer that question. As they grow and they continue experiencing those symptoms, then maybe a year afterwards they go, oh yes, I've been hearing that for about a year, right? So sometimes the symptoms have been there for a while, they just don't know how to verbalize them. Parental interpretation. I mentioned that sometimes what the mother sees is not necessarily what the father sees. So it depends on the interaction that the parents have, or the interaction, for example, that the teachers have. So someone, for example, the teachers might feel that the behaviors are improving, but the teachers maybe have started working on a structured environment, while at home, the behaviors haven't improved or the child has not shown any improvement, right? So we have to be careful with the interpretation of how actually the adults are seeing what's going on. And then sensitivity to environmental factors. Kids are very sensitive when it comes to things that are occurring in their surroundings. The tax test. The word comes up and they start getting anxious, right? Especially even if it's just a sibling that's taking the tax test, it becomes kind of an anxiety-provoking situation. So if that's going on, maybe we're seeing some anxiety. Does it mean if the child is being treated for anxiety, the medication is not working? No, we have to be aware that there are other things in the environment. Maybe nowadays with the economic problems, the children are perceiving that the parents are stressed out also. It's not necessarily a mental health issue of the child, it's that their environment is more stressful, more anxiety-provoking. And so they are going to demonstrate some symptoms that are not necessarily part of a diagnosis of a mental health diagnosis. Now, it's important when we talk about medication to understand that it's important that for a medication to work, one of the things that has to be done is they have to take it, right? And compliance is a big issue. Compliance of medication in the smaller age groups depends a lot on the parents. In other words, if the parents are really, really invested in the medication treatment. If they're not, the children aren't going to remember to take the medication. It really depends on the parents. So establishing a therapeutic alliance and having the cooperation of the parents, as well as the patient, as well as maybe the nurse at school, is very, very important. They also have to understand, especially the parents, they have to understand what the medication's for. If you just say, this is to make your child feel better, but if the parent doesn't have the specific ways of measuring if the child is, what does getting better mean, right? So, for example, anger outburst, and you discuss actually the objectives. Decreased anger outbursts. So if the child's having 3 a week, then we'd like to be able to measure that. So they see the need for the treatment based on those specific goals in the treatment. Also understanding the disorder and the expectations of the treatment, which is expectation what we just discussed. Understanding the disorder. When you tell a parent that their child has bipolar disorder, they don't know what you're talking about. They've heard the word, they might know that it has to do with mood swings, but they don't necessarily know what the disorder is about. They don't understand the origin of it. So education of the mental health issues is very important. Fears of medication treatment. You hear all the time on the news, especially, not FDA approved, or antidepressants cause suicide, just the side effects, sudden death, and we're going to discuss all those. That is very scary for a parent, to put a 5, 6, 7-year-old on medication that might cause all these things, and that child won't even know what's happening to them, right? So it's a big responsibility for a parent to give consent to medication, and that's why education is also very important. Developmental limitations. I can't tell you how many kids just don't like to swallow medication. It's just not something that's easy to do. And some of these medications, you can't open them up. You can't kind of hide them in peanut butter. You can't hide them in the food. So this is a big limitation in the younger groups. And in very anxious individuals, swallowing is a big deal. It's not an easy thing to do because they get nervous about it. They think they're going to kind of choke or it's going to get stuck. So all these things are important to evaluate. The kids are not going to tell you at the beginning. They'll only, after they struggle with their parents at home, then they'll say, I didn't take it because I was scared to take it. Or the taste.